Hello everyone. October is Breast Cancer Awareness Month, and on occasion of this awareness program, we want to talk a little bit about breast cancer today. I am Dr. Aditya. I am a medical oncologist at Apollo Hospitals, Bangalore, and I'll be hosting a informative podcast session on breast cancer. With me, we have three expert colleagues over here. We have Dr. Jayanti, who is the lead and robotic surgeon in breast surgery.
Hello.
We have Dr. Vikram, who is a senior consultant in radiation oncology at Apollo Hospitals, Bengaluru.
Hello.
And we have Dr. Vijay Agrawal, who is a lead and senior medical oncologist at Apollo Hospitals, Bengaluru.
Hi.
So, we would want to take this opportunity to talk about what are the common myths, how advances in breast cancer have changed the face of treatment and how effective treatment has become. Let me start by dispelling the one big myth. Is there any risk factor? What are the risk factors for breast cancer? Dr. Jayanti, can you talk about some risk factors, please?
Yes, so there are some women who have a little higher risk of developing this disease. These are the women who do not breastfeed for whatever may be the reason. Actually, breastfeeding a child is actually protection for the mother against breast cancer. And there are many studies which have shown that a woman who breastfeeds for at least 1 year has reduced risk of breast cancer. Secondly, when the first child occurs after the age of 30 years, again such women are at higher risk of developing this disease. Obesity is a huge disease which we see in our country, and there are many studies which have shown that women who are physically fit, who have an appropriate BMI, have reduced risk of developing this disease in the future. Alcohol, smoking, again, are high risk factors. There are also some women who have a strong family history, and in such cases we can actually do the genetic testing to assess whether that particular lady has increased risk of developing this disease or not. So there are a lot of factors, risk factors, which are in our control, and if we take care of it, we can reduce the risk of breast cancer happening in the future.
Thank you so much, Dr. Jayanti. So, Dr. Vikram, just touching upon a topic which Dr. Jayanti brought out, is there increased risk of developing breast cancer if somebody undergoes routine screening scans? Now, there is a big fear that if people undergo mammograms every so often, the radiation risk itself can increase the risk of developing breast cancer, or do frequent X-rays increase the risk of developing breast cancer?
Any exposure to X-rays, especially the low-dose X-rays, there is always a slight increase in chances of developing a cancer in the long run. That's why there are strict norms or guidelines that who has to undergo these screening programs, especially in the age group above 45 or in the postmenopausal set of people. It's better to undergo a mammogram. In the younger age group, there are something called as sonomammograms, which uses sonography in detecting these cancers.
Thank you very much, Dr. Vikram. Dr. Vijay, so can you summarize for all of us as to which is the most ideal way to screen for breast cancer?
So when you talk about breast cancer screening, I think first of all we need to identify whether you're at a higher risk of developing breast cancer or a standard risk of developing breast cancer. And by higher risk, I mean when you have one of the risk factors that Dr. Jayanti just mentioned, and also if you have a very strong family history and particularly a known BRCA mutation, and that increases the risk of developing breast cancer. Now the standard screening process is to have a mammogram once in 2 years, once you hit the age of 40, and that kind of continues up to the age of 75 if possible. People who are at a very high risk of developing breast cancer, such as if they have the genetic mutation or a strong family history, should probably do it annually. I think that is a reasonable approach in terms of how we screen for breast cancers.
Thank you so much, Dr. Vijay. So, Dr. Jayanti, let's say a mammogram has picked up a suspicious lesion. How do we proceed? How do we diagnose breast cancer?
Right. So once a patient comes to us, we first thoroughly examine them, take a detailed history, and we ask for certain imaging. It may be either a mammogram or ultrasound or breast MRI, depending on the age of the patient. Now, if the radiological findings suggest that there is a suspicious lesion, that is when we have to do a test called as a biopsy. Biopsy is a simple test wherein we put a needle into the abnormality, we extract a little tissue from it, and we actually study it under the microscope to know what is the type of the disease that we are encountering. Because in the breast there can be lumps which are of hundreds of types, and each one has a different treatment, and biopsy is what will differentiate one from the other. So luckily in our hospital we have started new services which is called as fastest and most accurate breast diagnosis. In this case, when a new patient walks into our outpatient, we examine them, we send them for radiology, they come back to us and we do a biopsy, and we get the biopsy report, and all of this happens within 24 hours. And I think this is extremely important. We are using it for more than a year now, and we've seen that a lot of patients are very appreciative of it, because all of them who walk into our OPD are obviously extremely stressed to know what the diagnosis is. Confirming the diagnosis within 24 hours is helpful, and also telling them that it is not cancerous is also extremely helpful. So 24 hours diagnosis, I think it's very unique, and I don't know any other center who's doing these kind of services that we call as FAMP.
I think so. That is a pioneering work which is being done at Apollo's in terms of getting a 24-hour outcome for anybody who has a suspicion of breast cancer. Moving on, Dr. Vijay, does everybody need chemotherapy? Does everybody with breast cancer need chemotherapy?
No. So the short answer is no. Breast cancer is not one disease anymore, and there are different types of breast cancers, and no two breast cancers are the same. So a lot depends upon the circumstances of the diagnosis, whether it's an early stage or an advanced stage, even in an early stage, whether it's a stage 1 or a stage 2 and 3. So there are various indications for chemotherapy, such as if the patient has got a locally advanced disease. And in those situations, we may need to give some chemotherapy. But very, very early stage disease, very, very small tumors, less than a centimeter in size, they may not need chemotherapy. Even when the cancer spreads, not all patients need chemotherapy. We nowadays do molecular studies, and we try to evaluate the molecular alterations in the breast cancers, and if they are hormone receptor positive, we tend to use more hormonal approach rather than chemotherapy. So even though the vast majority of the patients may need chemotherapy at some point in time, it is not necessary that all of them do need chemotherapy.
So I think along with chemo comes the question of the side effects, Dr. Vijay. Is there anything we can do? I think a big point for most women is the hair loss. Is there any way we can deal with the hair loss? What are your recommendations there?
Yes, so hair loss, so the most commonest drugs that are very effective in breast cancer are your anthracyclines and taxanes, and unfortunately both of them cause hair loss, and most of the time the hair loss is total, and occasionally it can be patchy. I don't really think there's much we can do about it. It's important to know that the hair loss is temporary and it will come back after we finish chemotherapy. Of course, we do provide a lot of support in terms of wig services and things like that to help them get through that period. But I think if you were to give the best treatment, particularly in breast cancer, the most effective drugs unfortunately do cause hair loss. However, there are still a lot of drugs that don't cause hair loss, as things like gemcitabine, carboplatin, and capecitabine. So all those discussions can be had, though there will be some trade-off between no hair losses versus efficacy. But I think those are decisions that we make along with the patients in terms of what their expectations are.
Coming back to you, Dr. Jayanti, a big concern for women is scars. You pioneered the concept of Scarless and robotic surgeries. Tell us about that, please.
Right. So one of the fears that women have, and also one of the reasons why women come to us late, they feel that if breast cancer is diagnosed, my breast would be removed and the femininity or the womanhood would be lost. And in my opinion, that's the reason why breast is not only a scientific topic, it is a very emotional, it has a socio-emotional repercussions of the treatment. So, and if we see the incidence of breast cancer is on rise, but if you look at it, there has been so much advancement in the treatment The 5-year survival rate of breast cancer is the highest amongst all the cancers, in spite of the rising incidence. So when we plan the treatment, we have to keep in mind the quality of life that we will give to the patient post-treatment. Hence, planning the surgical treatment is very important to keep the cosmesis or the femininity of the patient. So we do what are called as breast conservation surgery, oncoplastic surgeries, and there are certain oncoplastic surgeries which are absolutely scarless. There is no scar seen at all. And now we have newly started, we are one of the first ones to start the robotic nipple sparing mastectomies, wherein we put an extremely small, almost invisible scar. The skin and the nipple of the patient, which is healthy, is kept intact, and the breast, which is enveloped by this skin, is taken out through the means of the robotic arms, and at the same time we do the implant reconstruction, and we use a material which is again a new material, which is a titanium based proline mesh, which is used to cover the implant, and we have seen wonderful results. We've already done about 10 surgeries, and this is extremely new, and very few centers in the world are doing it. And patients are very happy with the outcome overall, and we can safely give radiation after that, even after the implant and the tie loop, which is the mesh that we use. So almost invisible scar, complete mastectomy, complete breast removal with reconstruction, all can be done in one go. So women need not fear. Breast does not have to be removed. The femininity is kept intact.
Most important message of the day. Taking that forward, Dr. Vikram, how does radiation work? Where is radiation effective in breast cancer treatment?
Okay, Dr. Aditya. So, radiation plays an important role in breast cancer treatment, especially when Dr. Jayanti has done a breast conservation surgery, and only the lump has been removed and the nodes have been removed. That time, giving radiation becomes very important, because we have to treat the whole breast and give radiation to the whole breast, and sometimes even to the neck area, what we call it as the supraclavicular area. So what happens during radiation is that these are invisible X-rays which help in killing the cancer cells so that they don't come back again. It is a form of local treatment. Like surgery, it is also a local treatment. What is visible is removed by Dr. Jayanti. What is not visible is going to be removed by radiation. So, whereas chemotherapy acts on the whole body, radiation and surgery acts locally. So, radiation becomes very important whenever they do a breast conservation surgery. The other places where radiation is given in breast cancer is whenever Dr. Jayanti has removed the whole breast, or what we call it as a mastectomy, and sometimes it is a little bit advanced and the nodes are positive. That time it becomes important for us to give radiation so as to sterilize and clean up the whole area. Usually radiation is given from Monday to Friday and not on Saturday, Sundays. So on a regular basis, the whole treatment gets completed in around 4 weeks. And in certain conditions, very early breast cancers, where after removing the lump, before, of course, chemotherapy should not have been given. After removing the lump, we can place implants called as brachytherapy in the tumor bed and give only that brachytherapy type of radiation at a later date after the after the sutures have been removed. So these are the indications for which radiation is given, and they are very essential whenever we are planning for breast cancer treatment.
So, Dr. Vikram, another question here is, there are so many newer modalities of radiation technique available. There is something called as a proton, something called as cyber knife. Is there a role for these newer modalities, and how much of an extra benefit it gives over the traditional methods of radiation?
A good question, Dr. Aditya. We are very happy and proud to say that Apollo has got all the latest techniques of radiation, be it cyberknife or a proton beam unit or ZAP technology or our latest advanced true beam STX, which is available in all our premises. So breast cancer has a very specific indication for treatment with all these techniques. We have correct indications for all these things, and we need to use them according to that. But the standard of care is always the true beam, which can serve as the purpose in treating the radiation to the breast, and also causing very less side effects to these treatment. When the cancer has spread to other locations, then cyberknife also can be used to treat these metastases, or what we call it as an oligometastasis. And certain conditions, as the indications are right, we could also use proton beam therapy, which we have it in the armamentarium. As of the left-sided breast cancers are concerned, we use something called as a deep inspiration breath holding, so that the dose to the heart or the cardia is kept to a minimum. And this we offer it to all our patients as a standard of care for left-sided breast cancer treatments.
Thanks, Vikram, for a fantastic answer on that. Moving on to the next question. Dr. Vijay, coming to you, the biggest advance in breast cancer treatment has been the advances in systemic therapy. Can you talk a little bit about immunotherapies or target therapies?
So when we're talking about breast cancer, I think most breast cancers now go through molecular screening process at the time of diagnosis. So we do something called next generation sequencing and molecular testing to identify whether there are any molecular alterations that might exist that we might be able to target. Okay. And the two groups of drugs that are really exploded in breast cancer is the anti-HER2 targeted therapy, and the other one is immunotherapy. So I think whenever you have a HER2 target that can be expressed or amplified, we have a lot of drugs against those particular receptors, and the new group of drugs are called antibody drug conjugates that were shown to be extremely effective in these group of patients. The other one is, of course, immunotherapy. Historically, immunotherapy has never been very useful in breast cancer, but the recent explosion in triple-negative breast cancers, I think immunotherapy has now become the gold standard of treatment in both early breast cancer as well as in advanced breast cancer. I think most of our patients end up getting some form of immunotherapy if they are triple-negative. And we started evaluating for patients whether they are more likely to respond to immunotherapy or not by doing PD-L1 testing and MMR testing and things like that. So I think a lot has happened, and most of our patients are benefiting from it. So with the help of all of these newer drugs, what we're trying to do is that even if the patients are in an advanced situation where the drug cancer is already spread, we're trying to make this more of a chronic disease rather than an acutely life-limiting disease.
Thank you so much for that, Dr. Vijay. So, Dr. Jayanti, I think a big question for patients women who have had breast cancer is what after treatment?
Right.
How do they live life after treatment? Can you throw some light on that, please?
Right. So once the patient completes, say, surgery, chemotherapy, radiation therapy, and if they are on hormone therapy, it doesn't mean that the treatment is completed. A regular follow-up is extremely important, and we certainly encourage our patients to come for regular follow-up. The highest chances of relapse are within the first 3 years. So initially for the first 3 years, we call them a little frequently to come for checkups, and then subsequently the number of visits will reduce, and then they have to just come once in a year. Now along with that, yes, it's important to take care of yourself. That means I would recommend some kind of regular exercise, which again reduces the risk of relapse in patients. Eat nutritious food, and it's also important that they calm their mind along with their body to do some kind of say yoga or meditation or some kind of exercise. Again, not only is beneficial for their physical body, but also mentally it helps you to relax. And that is certainly what we recommend, and we have a support group for that. We have a very vibrant breast cancer survivors group, and every new patient who walks into our OPD is connected to one of the survivors, and they actually emotionally support these women to go through the treatment. And the support group is always there to support each other. It is run by them. It's a very active WhatsApp group. There's a very active Google Meet, and we meet very often, where there is a lot of support available. And And this year, October's theme is that no woman should suffer breast cancer alone. And it so relates to the support group that we have in our department, wherein the motto is that nobody is alone, and there is not only the scientific support, the medical support that comes from all the doctors, but there's also emotional support which comes through our patients who have already gone through the treatment.
I think that's a very, very positive message for us to try and close this discussion on. To summarize, breast cancer treatment has undergone improvement by leaps and bounds. There is more effective systemic treatments to make sure the survival improves. There is more effective newer techniques to maintain cosmosis, and above all, just the end of treatment is not the end of life. The end of treatment is the beginning of life. Thank you very much.
Thank you.
Thank you.